this topic, the menopause, we are going to start off with the biochemistry and clinical presentation of menopause. As Dr. Mushiri has said, let's get the basics so that we understand how you investigate these women, why you would prescribe certain menopausal therapy, and why not the others, the complication as we go along with the series of this topic. So most of our women will come to us, or even you as clinician, when we see these women presenting with these symptoms: anxiety, hot flashes, mood swings, vaginal urinary symptoms, and all those. We try to question ourselves, is this menopause? Or could it be another pathological condition? What are we dealing with here? Because a number of women, you'll find most of them going from one doctor to another, and by the time they get diagnosed with menopause, they've gone through a lot. Some of them even end up with a psychiatrist because of the depression, anxiety, and the mood changes. So most of us will ask ourselves, is this woman dealing with menopause? Or even the women themselves would ask themselves, am I dealing with menopause? Because menopause can kick in any time, not necessarily at the normal average age. So what is menopause? When you talk of menopause, the natural menopause, it is defined as the permanent cessation of menstrual period, which is determined retrospectively after a woman has experienced 12 months of amenorrhea without any other obvious physiological or pathological cause. The average or the mean age of menopause is 51.4. Some literature will talk of 51, others 52, which comes to the same average. Menopause is a reflection of complete or near complete ovarian follicular depletion, which is resulting due to hypoestrogenemia and high follicle stimulating hormone concentrations. So you'll find the keyword here is the hypoestrogenemia, the low estrogen levels. So briefly, let's remind ourselves on the hypothalamic pituitary ovarian axis, because this will help us understand how these biochemical variations come about. Remember, from the hypothalamus, which secretes the gonadotropin releasing hormone, which will act on the pituitary, that will release the follicle stimulating hormone and the luteinizing hormone. Now, these are the ones which will act on the ovaries to produce estrogen and other hormones. And then once the estrogen levels are high enough, it will send negative feedback to the pituitary and the hypothalamus to stop producing the FSH and GnRH, the gonadotropin releasing hormone, and that way keeping the levels within the normal range, and you continue having the normal physiological changes and the menstrual cycle throughout the reproductive age. So when you talk of stages of menopause, a woman goes through different stages or phases in their life, where the first stage is the normal reproductive life, which we also call it premenopause. So during this stage, it's the normal reproductive life, which is around the age of 13 to 35 to 45. There's a range there. After during the perimenopausal period, where the woman will now, with the beginning of the perimenopausal period, the woman will get her last regular period. So throughout the perimenopausal period, you will see the estrogen levels are erratic. There are changes in the estrogen levels. So at this point, women tend to get irregular periods of varied duration and cycle length. And you find some of them even at some point missing their periods. And then it reaches a point where now they will get their last menstrual period. So after 12 months of amenorrhea, this when now the woman is diagnosed to be menopausal. And then after a certain period, which is around 1 to 3 years, then these women are now referred to as postmenopausal. So when we look at the biochemistry, on this slide, this is a comparison of the relationship between age and primordial follicle number in the block study of 44 female age 7 to 44 years, and that of Georgian study of female age 45 to 55 years, looking at the follicle depletion, which appears to be accelerated in the decade preceding menopause. So basically, in the block studies, these ones are looking these are the women in the block study between the age of 7 to 44 years, and these are the women in the normal reproductive age. And then in the Georgine study, we have the women who are in the menopausal transition. We have perimenopausal and postmenopausal. So you can see how the primordial follicles are declining throughout the 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 stages. So in menopause, it is associated with marked decline in the oocyte number that is attributed to progressive atresia of the original complement of oocyte. And there is limited evidence for absolute oocyte depletion at this time. There is evidence to show that there is residual oocyte and differentiating follicles which have been identified in the ovaries of some postmenopausal women, although these follicles are frequently atretic. So you can see these oocytes are still seen in the postmenopausal women. However, they are usually atretic. This one is showing the stages of reproductive life using the straw staging, which is the stages of reproductive aging workshop. So you can see that the same stages, the reproductive age, menopausal transition, and postmenopausal. In the straw classification, they subclassify them to early, peak, and the late reproductive period, where at this point, in this stage, the duration is usually variable in terms of years. At what point are you in the early reproductive phase or peak? There is no range. Usually, there is a variable number of age depending on your genetics, physical exercise, diet, among other things. And then in terms of their menstrual cycle, in the early reproductive age, the women usually have variable menstrual cycle to regular. And during the peak reproductive age, you'll find they have regular periods, and also in the late reproductive age, where towards the early late reproductive age, the period will be regular, but as they go towards the menopausal transition, you'll find some subtle changes in the flow and strength of the menstrual periods. As the woman enters now menopausal transition, where in the early menopausal transition, you'll find they have variable, the age is usually variable with variable length of the menstrual cycle. It can be persistent, or you can have a difference of 7 or more days in length of the consecutive cycle. Now in the late menopausal transition, which lasts about 1 to 3 years, some literature talk of up to 4 years. In this group, you'll find these women get an interval of amenorrhea of 60 days or more, which is usually followed by heavy menstrual flow due to the endometrial hyperplasia. And then you'll find now in the postmenopausal period, where in the early postmenopausal period, which usually lasts about 2 years, now these women are not getting any menstrual flow. But however, in terms of their endocrine, the FSH is usually variable with low AMH inhibin and very low antral follicle count. In terms of symptoms, in the early menopausal transition and in the late menopausal transition, and the early postmenopausal phase, you'll find these women is when they start experiencing the vasomotor symptoms like hot flashes. And as they progress to the late menopause, that's when now they start developing the urogenital symptoms like dryness and dyspareunia. Now, when looking at this slide, we are looking at the changes in these hormones, now the biochemistry. You'll find that the serum inhibin B, which is a granulosa cell protein marker reflecting the oocyte number, begins to decrease, allowing increase in the serum FSH, while the levels of the estradiol levels are preserved. In the luteal phase, you can see this is comparison. This is older female. The one in red is for the age of 35 to 46, and the blue is for the younger female at the age of 20 to 34 years. So the inhibin B is not typically measured to assess a reproductive stage, and the menstrual cycle for the are usually ovulatory, but the follicular phase begins to shorten. You'll find these women from The follicular phase being 14 days, it is shortened to about 10 days. And after this stage, you will find that these women who are having difficulty conceiving, that's the point where now they start seeking advice about the menopausal stage. That's when they start wondering, why is it not happening? So these women are typically in their 40s when the cycle begins to shorten. So you can see in all this, like in the younger women, the inhibin B is high, yeah, the progesterone is high, but FSH is low. In the older women, the LH is high. Sorry, this is for the younger women. The LH is high. The estradiol is low, and the inhibin A is higher than those of older female. When at the point of early menopausal transition, this begins on average of about 4 years before the final menstrual period, and it can take up to 10 years. And at this stage, it is characterized by irregular menstrual cycle. They'll have marked hormonal fluctuation. They might start experiencing the menopausal symptoms, especially the hot flashes. So in the early menopausal transition, which is usually defined as change of 7 or more days in the intermenstrual interval, where the women will begin to experience some menstrual irregularities. As we all know, the normal intermenstrual interval is about 25 to 35 days. But now at this point in the early menopausal transition, the intermenstrual interval is increased to about 40 to 50 days. The inhibin B, so the red is for the normal, yeah, in the normal reproductive group, and then the blue is for the perimenopausal. So you can see the inhibin B and AMH concentration will fall due to decline in the follicular number as a result of the serum FSH level, which will begin to rise with relative preservation of estradiol secretion and normal or high estradiol level, but low luteal phase progesterone concentration. So remember, when you're talking of estrogen, we have 3 types of estrogen. We have the estradiol, estrogen, and estriol. The estrogen is the most potent estrogen in circulation. The estrogen, which is usually produced during pregnancy and a very significant amount in during non-pregnant period. And then the estriol usually is produced in the peripherals from the fatty cells, from the fat, and some amount from the adrenal gland. So during the reproductive age and the menopausal transition, when you're talking of estrogen, we are mainly referring to the estradiol. With the onset of menopause, you can see this red, this is for the levels of FSH, this is the LH, and then here we are talking of the estradiol, and then this is the inhibin, yeah. So in the late menopausal transition, you start experiencing cycle variability. The women will progress to more dramatic menstrual cycle, and changes they might also get skipped cycles. The episode of amenorrhea are mostly experienced during this period, and they might start experiencing increasing frequency of anovulatory cycles. This period can last up to 1 to 3 years before the final menstrual period. So here you have fluctuation in the concentration of FSH and estradiol, which might be quite striking. There's usually high FSH, the follicle stimulating hormone, and low estradiol values, which might be suggestive of menopause, but sooner thereafter, the FSH and the estradiol might return to normal premenopausal range. At this stage, the women also can experience progressive decrease in the serum inhibin B, as well as decrease in the anti-Mullerian hormone. The ovarian antral follicles count usually decline steadily across the reproductive years throughout menopause. So as much as we see these changes, the anti-Mullerian hormone antral follicle count day 3 of FSH level, estradiol, all have been used to assess ovarian reserve in the setting of assisted reproductive technology, but none are validated for evaluation of menopausal status. In our series of presentation, one of my colleagues will talk about evaluation of these women, and they'll take us through how you are going to evaluate to diagnose menopause in these women. The inhibin B, which is typically measured during diagnostic evaluation for ovarian tumors, but it is not for evaluation of menopause. So as much as you see the changes in these hormones, you can't really, when a woman presents with this symptom, you can't really, as in this, they're not validated for you to send them for this test to actually confirm menopause. However, my colleague will elaborate more on this. So when you're talking of menopause, and when I speak of menopause, I'm referring to clinical menopause. And again, one of the series we'll talk is the premature ovarian failure, or the iatrogenic menopause that sometimes women end up experiencing due to other causes. So here we're talking of clinical menopause, which is the permanent cessation of menses, and the final menstrual period is usually defined retrospectively after 12 months of amenorrhea. So when I'm talking of menopause, there is the early postmenopause, which usually lasts 2 to 6 years after the final menstrual period, and then there's late menopause, which is the years after. So what are the factors affecting menopause? We have initially, I alluded that the actual age when you're actually experiencing menopause is dependent on a number of factors. So when you're looking at genetics, women with family history of early menopause are at higher risk of undergoing an earlier than average menopause themselves. So there is additional evidence that genetics play a role in the normal variation in age at natural menopause. So family history, and then there's the gene regulating DNA repair. We also have the fragile X messenger ribonucleotide prematuration, which has been associated with premature ovarian failure and earlier age of menopause of up to 7 years. Ethnicity, there is natural menopause occurs earlier among Hispanic women and the Japanese American women compared to the white women. When we're talking of night shift work, this one I know it's alluded that women who work for night shifts for more than 20 months continuous do experience early menopause, and it is thought to be due to change in the circadian rhythm or the disruption, or is maybe due to fatigue and stress associated with demanding work schedules. So the cause, a number of night shift will cause a number of adverse effects on reproductive health, which may also impact on the age at menopause. A prospective cohort study of 80,000 women who were followed for 22 years showed that those who rotated in night shift for more than 20 months in previous 2 years had an increased risk of earlier menopause compared with women without having worked for night shift. So the risk was stronger among women undergoing menopause at under the age of 45. Another risk factor is smoking. Smoking 1 to 2 years earlier than you, women are at risk of developing menopause 1 to 2 earlier than the average population. Hysterectomy with ovarian conservation. This appears to alter the ovarian function in the long term, even if the ovaries are reserved. So even when you do a TAH, even if you reserve their ovaries, these women tend to get menopausal symptoms, and it is thought to be due to impairment of ovarian blood supply. So what are the clinical presentations of menopause, or the symptoms of menopause? So we can broadly divide them into two groups. We have the CNS, or the vasomotor instability. We have the genitourinary syndrome of menopause, which is abbreviated as GSM, and we have other symptoms. So when you talk of the vasomotor symptoms, these include hot flashes, night sweat, sleep disturbances, depression, cognitive changes, Under the genitourinary syndrome of menopause, we have the sexual dysfunction where the women will present with dryness, dyspareunia, or low libido. Some will present with stress incontinence and even pelvic organ prolapse, which usually are also attributed to other factors, but also most of these women will present at the stage of menopause, not during the reproductive age. So it is thought also due to the level of the estrogen that it's exacerbate this presentation. The other symptoms include joint aches and pain. Women might present with breast pain and menstrual migraines. So we'll go through some of these symptoms, not all of them, but most striking symptoms. You'll find hot flashes usually begins very early. It is the most common symptom during the menopausal transition and also in the early menopause. It occurs in up to 80% of women, with 20 to 30% of women seeking attention for treatment. So it is thought that the hot flashes are actually more common during the menopausal transition, with a frequency of approximately 40% in the early transition, which will increase to 60 to 80% in the late menopausal transition and early postmenopausal periods. So these women will present with sudden sensation of heat centered at the upper chest, face that is rapidly becomes generalized over about 1 to 2 minutes. It's associated with profuse perspiration, palpitations, and followed by chills and shivering and a feeling of anxiety. So you can imagine a woman who has never experienced hot flashes all of a sudden is feeling these things. Some of them will even come to you thinking that they have been bewitched or something. So the symptoms might occur several times in a day, although the range might vary from only 1 to 2 in a day to as many as one per hour during the day and night. The hot flashes are particularly common at night, which we will see that how now they bring about other symptoms of the vasomotor symptoms. So hot flashes, the duration usually diminish and stops within a few years of onset of in most women, but it can persist for as long as 20 years past the final menstrual period. So the hot flashes will have impact on function and on work, where it interferes with sleep in up to 90% of women. Remember, it occurs mostly at night. These women it might also affect their concentration, mood, energy, and sexual activity. On the impact of work, hot flashes and other menopausal symptoms have a negative impact and outcomes, including absenteeism, decreased hours, layoffs, firing, and job change. When you go to depression, there is increased risk of new onset depression in women during the menopausal transition compared with their premenopausal year. So within woman 8-year longitudinal study to determine the risk factor for depression disorders, a diagnosis of depression was 2.5 times more likely to occur in the menopausal transition compared when the woman was premenopausal, with an odds ratio of 2.5. So this association is most marked for women with a prior history of depression or mood problem. So if you had a prior history of depression and then during the menopausal transition, then these women are at higher risk of getting depression during the menopausal transition and early menopausal stage. So due to these hot flashes occurring commonly at night, these women end up being aroused from sleep, and now it results in sleep disturbances. It's also common in the absence of hot flashes. So this will also bring about anxiety and depression. It has a prevalence of 32 to 40% in the early menopausal transition, and the prevalence increases to 38 to 46% in the late transition. So primary sleep disorders are also common. In a report of 102 women aged 44 to 56 years who reported sleep disturbance, 53% had sleep apnea, restless leg syndrome, or even both. So testing for vasomotor symptoms might be or might not resolve, treating vasomotor symptom might be or might not resolve sleep disturbances. So it is mainly thought to be due to the vasomotor symptoms. So but however, some women, even after treating their hot flashes, they will still get sleep disturbances, which will lead now to anxiety and depression, and also will affect their function during the day. They'll have day fatigue and other things. When we look at cognitive changes, there is substantial biologic evidence which supports the importance of estrogen to the cognitive function. Estrogen receptors have been identified throughout the brain and appears to particularly be concentrated in the basal forebrain, which is of special interest since it is the major source of cholinergic innervation to the hippocampus. So female appear to be at greater risk than males for eventual age-related dementia and memory impairment. Some evidence suggests that in early midlife, the female appear to outperform males on memory tasks, but with the onset of menopause and decline in the serum estradiol, any memory advantage is diminished in these women. During menopause transition, some women describe bothersome memory symptoms. You'll find that they complain of being forgetful. They have difficulty with word retrieval, or even some of them will describe as getting brain fog. And anxiety and depression has independent and unfavorable effect on the cognitive performance. This is according to the SWAN study, where the estradiol has been found to protect against changes resulting from serotonin withdrawal and defend against changes from cholinergic depletion. So there is support from the critical timing hypothesis that estrogen benefits cognitive function when instituted early but not later. So it's good for these women as soon as they during their menopausal transition, they start experiencing these hot flashes and all that, that it's early recognition is good, so that you can institute the medication early in time to try to make sure that they benefit from the treatment. And the genitourinary syndrome of menopause, which is abbreviated as GSM, which is formally referred to as vulvovaginal atrophy. Here you have a collection of symptoms and signs caused by hypoestrogenic change to the labia, clitoris, vagina, urethra, bladder that will occur in the menopausal women. So estrogen deficiency will lead to the decrease in blood flow to the vagina and the vulva. And it is thought that GSM develops later than other menopausal symptoms like hot flashes. So most of these women will present with genitourinary syndrome of menopause in their late menopausal stage, like not during the early menopausal, postmenopausal stage. So as a result of hypoestrogenic vaginal changes, these women will have thinning of the top layer of superficial epithelial cell. There's loss of rugae in the vagina. There is loss of elastability, shortening and narrowing of the vaginal canal, increased subepithelial connective tissue, reduction in the vaginal secretion from 3 to 4 grams in 4 hours to 1.7 grams in 4 hours. And there's also increase in the pH. So all this now will result into dryness, dyspareunia, and other symptoms. The symptoms which are related to genitourinary atrophy are exquisitely responsible for the estrogen therapy in particular. So you'll find in most women who present with menopausal symptoms, those with genitourinary syndrome, when they're given topical estrogen, they respond much faster and the effect is very significant. So what are the clinical manifestations of genitourinary syndrome of menopause? So these women will usually present with complaints of vulvovaginal dryness, decreased vaginal lubrication during sexual activity, dyspareunia. They might even get postcoital bleeding and labial fissures, some bruising, decreased arousal, orgasm, and sexual desire. They will present with vulvovaginal burning, irritation, itching. Some will have levator spasm and urinary tract symptoms. A few can present with urethral prolapse and caruncle. So when you examine them, you'll find that the labia minora resorption, there's labia minora resorption or fusion. There is tissue fragility, fissure, and petachia from the bruising. There'll be introital retraction, loss of hymenal remnants. There's prominence of urethral meatus for those who will have prolapse, urethral eversion and prolapse, vulvovaginal pallor, erythema, loss of vaginal rugae, decreased vulvovaginal secretion, decreased elasticity, vaginal discharge, and spasm. So what are the long-term consequences of estrogen deficiency? So we've looked at the short term where they'll have the hot flashes, the genitourinary symptoms of menopause and other symptoms. But now what are the long-term consequences? Due to the ovarian, since the ovarian estradiol production and secretion decreases and stop altogether after menopause, though some literature talk of a small amount of estradiol still in circulation, not enough to preserve all this function, but there's still some amount. And it is thought that some estradiol is obtained from the conversion of estriol to estradiol from the fat deposition. However, the ovary continue to secrete the testosterone. So there is a number of long-term effects of estrogen deficiency, which include bone loss with osteoarthritis, cardiovascular disease, dementia, the body composition, skin changes, and balance. One of my colleague will go through these things, especially in relation to hormonal replacement therapy. So when we look at this chart, this is basically a summary of what we've been talking about since the beginning. You can see due to the low estradiol level, we have the CNS and the vasomotor symptoms. We have the genitourinary syndrome of menopause. There's the cardiovascular risk and the bones being affected. So you can see the changes where there's usually increased norepinephrine and serotonin, leading to narrow thermoregulatory set point in the hypothalamus. So the women will present with hot flashes, night sweats, sleep disturbance, depression, and these will lead to depression and daytime fatigue. So you can see here the treatment is estrogen. When you look at the urogenital mucosa, where when you have low collagen synthesis, you have weakening of the vaginal walls, leading to stress incontinence and the pelvic organ prolapse. And due to low blood flow to the vaginal epithelium and the vulva, you have a reduced glycogen production, leading to reduced energy source for lactobacillus, increasing the pH. And with this, you'll also have reduced secretions and epithelial atrophy. So women will present with dryness, irritation, increased risk of infection, and dyspareunia. Again, treatment estrogen. Since the main point is, since the main problem is low estradiol, so you just have to give exogenous estrogen. Again, in the cardiovascular, when you're looking at these women will end up getting very high cholesterol, high LDH and low HDL, and eventually they'll have high risk of atherosclerosis with increased risk of myocardial infarction. So here estrogen only plays a role before there's plaque formation. However, if you give it late, then it is of no use. So time is of the essence in these women. Again, when you look at the bones, there's reduced osteoclast, apoptosis, there is reduced secretion, the OPG secretion by the osteoblasts, and they eventually end up with bone resorption, formation, and they get osteoporosis. So here the treatment is usually serotonin, the SRMs, estrogen, and biphosphonates. That is the end of my presentation. Thank you.
I think there's someone who's not muted. If you could just try and mute your audios. Thank you, Charles. Thank you so much, Dr. Busra. I was taking notes and getting inspired because you have really taken us back to the basics, at least for those ones who cannot remember some of these things. But even for the people who are just fresh out of school, revising is always good, and it sets a nice base for our conversations that will be coming over the next couple of weeks. So I can't see any questions. I would be hard-pressed to think Dr. Busra has answered all our questions on the basics, but let's see if someone has a question. You can lift your hand up or put it in the chat. Dr. Busra, I think people are taking in all that information.
Or are they lost altogether?
Oh yeah, they could be lost. I hope they are not lost. I think it was quite nice how you broke it down, and the information was quite clear, not too loaded. So I really enjoyed your presentation. So I'm thinking there.
Maybe there there's somebody who raised their hand up.
Someone has raised their hand. Dr. Wera, if we can welcome you, our very good senior. I know you have an interest in the area, especially when it comes to down below. Feel free to ask your question, please. Thanks.
Thank you so much, Dr. Busra, for your nice presentation and taking us back down memory lane on menopause. Now, this is an area of particular interest to me because, despite aging, beauty doesn't go away. True or false? True. And so,
True.
when these ladies come with, GSM symptoms, as you mentioned, of menopause.
Mhm.
So besides maybe probably using HRT, are there any new novel ways that you manage them? Because some of them would want to get back their sexy lives. Some of them are into new relationships after maybe a bereavement or divorce and so forth. So is there anything new that we may want to benefit from?
Okay, as I mentioned earlier, we are going to have a series of these presentations. The next will be on evaluation, then we'll come to treatment. But just briefly to answer your question, as I was going through my reading. For GSM, again, you'll address the woman depending on their symptoms. If their symptoms is dyspareunia or dryness, and being postmenopausal, then you'll give them the estrogen, the topical estrogen for them. But if their problem is like, let's say, shortening of the vagina, or maybe due to the loss of rugae and other things, I don't know, you are the expert in this. I don't know if there is any role of surgical intervention or anything, but with regard to the menopausal symptoms, it is thought that the topical estrogen, in fact, when treating the menopausal symptoms using estrogen, the topical estrogen take care of 80% of these menopausal complaints or symptoms. So in terms of other interventions for them, of course, there is the issue of psychotherapy, there are nutritional, there's counseling, but I don't know, in your field of expertise, what do you say? Is there a role of surgical intervention in these women?
Well, surgical, not so much, yeah? Because of course, like you said, you expect with menopause, there may be a bit of laxity expected due to loss of collagen and so forth. But then again, you mentioned that the genitalia generally shrinks. So maybe surgery may have no part to play there. However, regenerative medicine, that is the use of growth factors, not necessarily stem cells, but growth factors, have a major role to play in trying to restore that which has been lost due to absence or reduction in the amount of estrogen that the ladies have in their genital area in menopause. Besides that, we also have the use of radio frequency that also helps them to some extent. It never quite restores their true selves that they were prior to menopause, but at least gives them some rebate to feel near normal. Thank you.
Thank you, Dr. Were. I can see we'll be onboarding you in that conversation. And I do agree with Busra, use of topical estrogen, but there are also other non-hormonal products in the market, including what, sort of KY jelly to reduce friction and basic, well, what sounds like basic, but just having that conversation. Dr. Kenya will be presenting HRT practical prescribing lifestyle and complementary therapies on the 14th of October. So that would be a really nice place to sort of have this conversation. I can see a question from Dr. Kibi. He's asking a 35-year-old with FSH of 96, what looks like low ovarian reserve and AMH was very low. Last period was 1 year ago. Do we assume she's menopausal? Dr. Busra, what would you say to that?
I would think of premature ovarian failure because of that age. The FSH is quite high, and with that level of AMH, so I would think most probably we are dealing with premature ovarian failure.
Yeah, so I agree with that, Busra. I'll be presenting on the 28th of October, premature ovarian failure, and we'll have more conversation about that, Dr. Kimi. Dr. Kigenru, thank you for appreciating the presentation by Busra. We've got a question, patients being managed for breast cancer and comes with complaints of painful dry sex. How would we manage these patients? And probably, maybe let me speak on behalf of Busra, again, coming to prescribing therapies, and we'll also be having a session with discussions with breast cancer surgeons on how they manage and what we do with them in terms of hormones. But these are patients who would benefit from non-hormonal treatments so that we don't put them at further risk. Dr. Nyongesa has given us a word of caution on the long-term users of Depo-Provera and progesterone-based FP methods. A lot of these ladies tend to be hypoestrogenic. So a word on their management, especially those who stopped Depo about a year ago, but are still amenorrheic. Dr. Busra, I think the question would be if you've got patients who have been on Provera or Depo for a long time, and then they come off, but they're still amenorrheic, how would you go about thinking through that in terms of the biochemistry and clinical presentation?
So women on long-term Depo-Provera or progesterone-based FP methods.
Yes.
Then they usually tend to be hypoestrogenic. So here you already know the cause, it's hypoestrogenic. Yeah. So you can give them a challenge and see. Yeah. Because now you go back to, you have to evaluate these women as much as you're thinking the cause is the long-term exposure of the progesterone, you still have to evaluate these women for secondary amenorrhea. Yeah, so this is now another topic. You don't just assume because they were on this type of family planning, so the issue is hypoestrogenic, and you start giving them estrogen. No, you'll have to evaluate these women for other causes of secondary amenorrhea, looking at their pituitary, the thyroid, and all those. If they are not there, then like this, the stepwise, the way we usually do it, and then you can give them the progesterone estrogen challenge, and then see. And then you evaluate them further. Then if you've not found any cause, then you can treat them with the estrogen. That is what I would do.
Yeah, maybe Dr. Nyongesa, that would be a good study to check whether they are actually hypoestrogenic.
Estrogenic,
how many of our patients on long-term Depo, and when we tend to see them, at what point they're coming, and is that then a question of whether that's inducing menopause earlier? We don't know. So that would be a nice place to investigate. Dr. Okello, thank you. She's asking whether she can have the PowerPoint presentation. I'm not sure, Busra, if you would be able to share that. I think the recording will be shared, but I'm not sure about the presentation in itself.
I can share to her.
Okay. Dr. Guer, thank you for your comment. Excellent presentation. Are there any drawbacks or absolute contraindications for topical estrogen? And then what is the value of soya? Might you have any input on that, Busra?
On absolute contraindication for topical estrogen?
Absolute contraindications for topical estrogen, and then what is the value of soya?
Okay, that will come under on the treatment, the presentation by Kenya on the prescribing, the treatment and the alternatives, which on this question can be answered. But in terms of the topical estrogen, I assume you are treating the GSM symptoms, yeah? So for these women, it is not systemic. Yeah, so I don't think there is a contraindication to that.
Yeah, so unless they have estrogen-specific tumors or that are local, sort of locally based, which is very unusual, even if you have vulval cancer or vaginal, but maybe vaginal, but vulval would be rare. What is the value of soya? I'd give my personal opinion. I think soya is great, but we are going to have a chat about complementary therapies. I have had a couple of patients who have had very good effect. I do warn them that they shouldn't take too much of it because it's a phytoestrogen, so it still gives you the risks of long-term estrogen, especially if there are people who would end up with endometrial cancer. So with caution. Dr. Kigondo is saying 8 weeks is a very long time for this series. So he has decided to ask his question. Lubricant in Atumiwa for how long? How long would you use the lubricant for? I normally say for as long as they need it. You'd find sometimes they actually do need it day and night, even when they're not sexually active. And basically they'll oil themselves normally as after they shower, and then they put some lubricant, and that takes them throughout the day with extra addition during the sexual intercourse time.
My earphones are not working. Can you imagine?
You can't go through it.
Masden,
No, I'm not.
Masden, you're loud. Please mute yourself. Okay, there's a question from Dr. Kagema. I had a patient today, 42 years, had an appendectomy at 9 years, then reports right oophorectomy at 13 years for unclear reasons. Never got Menake, but bleeds on the combined contraceptive pills. Scans, no ovaries are seen. She has vaginal mucosa and cervical atrophy, some mild incontinence, HRT or not.
So just you're thinking it could be iatrogenic?
Yeah, so that looks like, I mean, they need, you need to investigate them and see what their levels, the hormones, as Dr. Busra has discussed, even though they may be not purely diagnostic, FSH, LH, estrogen, progesterone, the full works. Because if she's had right oophorectomy at the age of 13, where is the other ovary?
Maybe they're thinking when she had the appendectomy, also there may be the
might have
left
removed,
ovary. Yeah.
They might have removed the right ovary, but you see on the scan, they're saying no ovaries seen. So
yeah, she needs further evaluation, maybe even if it's diagnostic laparoscopy or an MRI first to actually confirm presence of these gonads or absence, then you can proceed to evaluate for the hormones.
Yeah, because it might have been that she never had, that ovary even then. So that's a bit, needs further investigation. Mutindi is asking, intravaginal RF reduced the clinical symptoms of GSM in most patients, especially during T1. And women, she's shared an article. Okay, fine. Dr. Mutindi, thank you very much for sharing that article. I think everyone can access it on the chat. Yeah.
Thank you.
All right. I think we are in good time. We've been here for about an hour, considering that this was an introduction to our series. Thank you so much, Dr. Busra, for taking us nicely through that. We will be doing assessment of women presenting with menopausal symptoms on the 7th of October, and we'll be sharing this series with everyone so that you've got the poster and you can attend whichever you sort of are interested in or whatever you're curious about, or all of them. I think it would be nice to attend at least all of them. Yeah. So thank you so much, Dr. Busra. I would like to hand over back to the great Dr. Mitei, so that
Thank you too, doctors.
Yeah, you can tell us. Yeah, so asante sana, Dr. Busra. Mitei,
Thank
over.
you too.
Thank you so much, everyone. On behalf of the members of the Coast Branch, thank you for joining us today. I would also like to thank our moderator and presenter, and indeed the presentation was quite informative, and as always, your strength of attention to detail has manifested to a point we almost had no questions. We were not lost as an audience, but had satiety. We were full, and we quite caught a few things, and it's good that we went back to the basics. As has been mentioned, we are going to be having a series over the next week to tackle various aspects of menopause, so that hopefully at the end of it all, we are all well equipped to make women go through this phase with the utmost comfort. Look out for the next poster and be sure not to miss any of it. As Dr. Mushiria said, it would be nice to attend all of them. Lastly, allow me to welcome all of you to our branch annual symposium on the 18th and 19th of October. Karibuni sana Pwani. Have a nice evening. Until the next, God bless you. You're free to leave.
Thank you, everyone.
Thank you.